everyone. Welcome to our sixth and final session of the SNAC VLC, Clinical Care Transformation Strategies. Can you believe how time has flown? I look back and I looked at the first session. It was all the way back in middle of June 14th, if memory serves me right. So we've gone through a lot of content in that period of time. So thanks to each of you for hanging in there with us and adding your comments and your contributions. Hopefully it's been valuable. I feel like we've kind of come to the highlight of the series, having each one of you talk about your organization, how you've applied the concepts from the VLC that we've taught you on, tips, the models we've shared, and really pulling the whole thing together. I know it's hard to do given we limited you on 7 or so slides, but the rollout today is we'll have each participant conduct their own presentation. I think in the interest of time, we're going to skip introductions, I think, or the round robin of introductions. We kind of sort of know one another by now, but we'll save that for each of the presenters to talk about who they are and a little bit about their organization. So I think what we should do in terms of ground rules, since this is a new experience for all of us, is let's have each participant present their material, and at the end, we're going to open it up for question and discussion, and I'd like to turn the tables a little bit. And rather than me talking or Natalie talking, I'd like to encourage each of you as participants to, give your colleagues feedback, either clarifying questions or suggestions and comments. We have got 6 presentations today from all 6 participants. I'm thrilled that each of you has hung in there the whole time. But an enemy for us is time. That will only leave about 15 minutes for each presentation. So I'll kind of be moving us along if we need to. But I think that would make sense just to give you sort of a cue up. You can see your name and what slides you've got. So if you're the next speaker, you might want to be watching the slides to see when your time is up. And there was no order. It was just sort of random that the slides were put in order. But with that, does that, in terms of ground rules, does that make sense to folks?
Sounds great.
Yep, works.
Okay, I'm excited. All right. With that, Marguerite, you want to take it and tell us the California story?
Sure. Can everybody hear me?
Yes.
You are good, Marguerite.
Okay. Great. So I'm Marguerite Tuthill, and I'm the planning analyst with the California Critical Access Hospital Network. And just a disclaimer, I don't have the slides up, so I'll let you know when I'm moving to the next slide. I don't have like the WebEx thing. Anyway,
no problem. AJ, do you want me to move the slides, and Marguerite, you cue me, and I'll move on.
Okay, great. Thank you so much. So California Critical Access Hospital, or we call it CCAN, is a statewide organization, and there are 34 members throughout California. And it's actually managed by the Western Healthcare Alliance, and so that's the company I work for. And that is another network of hospitals, of rural hospitals, but in the western slope of Colorado. So these are just 2 big rural hospital networks that are pretty robust. And CCAN has a main purpose of creating collaborative working relationships. And one of the things they're starting to focus on is how do they approach value-based transformation and get ready for 2019 and MACRA and the new world that's coming. So the way they did, and if we want to move to the second slide there, what CCAN has decided to begin with, we did do about 3 years of work moving into researching which models or which value-based model they wanted to begin with, and lots of time with consultants and really looking at what the membership populations are and what the resources available are. And we ended up deciding that 6 of the member hospitals, the CCAN member hospitals, are going to participate in the Transforming Clinical Practice initiative, so TCPI, and this is going to be seen as a stepping stone to more advanced value-based models. So there was a lot of talk about possibly involving members who are interested in getting going on this work in accountable care organizations, but the feeling was that that was a little too much to take on at first. So we're starting with practice transformation, and it's going to focus on primary care clinics, but we're also going to include any specialty clinics that are interested. And as I said, 6 of the 34 joined up, and then they're going to be reporting back to the CCAN board how it's going and what they've learned, and hopefully prompt more participation. And we're going to start this in October 2016. So right now we're just finishing up building infrastructure and getting staff in place, and then we'll get it going in October, and TCPI is going to last for 4 years. So we can move to the next slide. So governance structure. So as I said before, CCAN is managed by the Western Healthcare Alliance, and just to add one more layer, and I wish I had included a picture of this, but CCAN and the Western Healthcare Alliance created a third company called the Community Care Alliance, which is specifically focused on population health management services. And so that 3 years of work that I mentioned, researching models and really figuring out how they want to get into it, that culminated in the creation of the Community Care Alliance, because the members wanted their own program and their own employees to kind of drive this work for them. So the Community Care Alliance applied to become a practice transformation organization in TCPI, and they were approved. And that's through the Practice Transformation Network that we're working through is the University of Colorado at Denver. And initially, the PTO was only supposed to focus on Colorado, but because our network connections are so strong, they allowed us to include CCAN in this effort. Which has been really exciting for us because it allows us to just maintain those connections. And then it also allows us to develop cohorts between Colorado practices and California practices. And so they have even more places to reach out to when they want to find out more about best practices or have any questions about how a certain practice implemented a workflow. So it's really creating more and more layers to the network connections that CCAN and WHA already have and have had for many years. So if we want to move to the 4th slide on high-risk cohorts. So right now, I guess our cohort, you could say, would be the practices, since we're just focusing on getting them up to speed and teaching them about workflow and team-based care capabilities and getting them ready so that when we move to more and more advanced clinical integration methods, they're able to risk stratify really well and really target that top 10% of patients. And yeah, we're good on that. So then our 5th slide, the identified interventions. These are just 3 of what we're focusing on. These 3 did come from a review of best practices that the Community Care Alliance did and then presented to CCAN practices, and they decided what they wanted to focus on. Access to appointments and cross-training staff are going to be what we're focusing on initially. Just really, like I said before, it's working on workflow, and the cross-training staff, which I find incredibly important, and I'm sure a lot of you experience this as well, is that there's high turnover in these rural areas, and it's difficult keeping good staff here and within our practices. And so the idea of cross-training the staff is that you have more than one person focused on this work. So if that one person leaves, it doesn't destroy the entire initiative. And then eventually we'll move to the care coordination of the top 10%, but we're really going to focus on developing capabilities of the staff and at the practice level before we start moving into those higher level interventions. And since we're beginning the work in October, I did mark all these interventions as to be implemented. And then if we move to the next slide on changes to be made, the big thing we're going to focus on first is a centralized care planning tool. And the reason we chose to centralize this tool is for a couple of reasons. From an administrative standpoint, we feel that the central tool will allow the Community Care Alliance to better assist the practices, because instead of us knowing just a little bit about each EMR, we actually have a really good knowledge of how this care plan works. And so we'll actually be able to help them when they call in with questions. And then we also are the gateway to the vendor. So if there's any kind of issue or if a new dashboard needs to be set up, anything like that, we can handle it. And then it allows the practices to spend more time providing care and not dealing with, lassoing the vendor into doing something that we want. The second reason is that the centralized tool includes a health risk assessment that we built, and it really focuses heavily on social determinants of health. And so we just wanted to make sure that this health risk assessment was tailored to our practices and tailored to the populations they work with. And then the other part of that health risk assessment and why we chose the centralized plan is that it allows for better data collection when they're all working at that same HRA. And so we can actually pool the data and analyze it across the practices instead of having to, factor in different EMRs and different questions and stuff like that. So we're going to have a better way to track outcomes of this practice transformation work. And so if we move to the data sources slide, I forgot to include the care plan tool, but that is one of our current data sources. We also have practice EMRs and provider knowledge for clinical data. And then we are relying on publicly available data, primarily community health needs assessments and then county health rankings data, which I've always really enjoyed that website. I think they've got some great stuff. And then for some potential data sources, we're looking into eventually getting claims data. And as I'll talk about, I guess I didn't talk about that in the governance, but eventually we want to move them into ACOs. And once they become an ACO, we can start using claims data and gain the information from that and just have that interact with the clinical data we'll be getting from the EMRs and provider knowledge. We're also working on, we're looking into developing ADT capability to get that information in and put that into the centralized care plan. And then we're also looking into building interfaces for CCDAs to also pull that into our data analytics platform. That is everything. I did include a contact information site. I do have to jump off. I'm at a conference right now. But any questions, please email or call me, and I'd be happy to answer anything you may ask.
You need to jump off now, or do you have a little time for questions?
I have a little time for questions, yeah.
Okay. Great presentation. I don't know if you ever sleep, given everything that you've got to do, but let's open it up to participants. Any questions or comments?
Excuse me, this is Jennifer at Lakewood. I think you did a tremendous job. This is for not necessarily having a one specific clinic or area that you're working on, but for working in a whole conglomerate. It is amazing, and you've done a great job of applying the things to that area. So I think it's really well thought out.
Oh, thank you. Well, and a lot of it is you got to give the credit to the members. Like, they're really, really dedicated to building a strong network and really working together across the regions. And that's just been really cool to see that these, in a lot of ways they are competitors, but at the same time they see like they want to remain independent, and they're recognizing that they're going to have a better chance of that by developing these strong networks. So that credit goes to the members.
Well, as a independent and wanting to stay independent, organization. I just think having you there to streamline everything and, like you said, get those practices set up and recognizing the challenges that the employees themselves may have or organizations have with retaining employees, I bet they are so thankful to have that. And truthfully, I think it's going to be instrumental in their success.
Yeah. Well, thank you.
Marguerite, second.
This is Tracy. I was just wondering about the social determinants of health education that you're doing. How did you kind of set that up? Because that's a huge thing for providers to really understand.
Yeah, I agree. We're still we're working on that. I think it's going to take a couple webinars. So we're starting just with a general webinar on what the social determinants are, and you know, the pie graph showing which percentage actually is clinical care, which percent are social factors, environmental factors, and so on. So that's kind of our intro. And then we're also, as I said, it's built into the health risk assessment. So as they go through the assessment, they're going to pick up on how these factors are impacting the patient, maybe a little bit better than if they were just sitting and just listening to our webinar. And then we'll also really focus on the social determinants of health and addressing those determinants during any of the cohort calls. And so that'll be a time when we can actually go into examples and practices who have found good ways of addressing them, or maybe they found a transportation program that works really well in their rural community. They can share that, and so providers will be able to learn that way. So we're kind of going at it from a few different learning methods. Did that answer your question?
Somewhat related, how are you using the county health rankings data?
That is more just for our education and kind of to point out what the social determinants are. Because what we started with is we looked at the community health needs assessments first and kind of did just a big graph showing the counties we work in and then the major topics that were identified in the health needs assessments. And we just did a red-green kind of color map to say these are the topics that these counties are focusing on. So you can do a quick glance and just see what they're focusing on. And then we went into county health rankings to see what the actual numbers are for that county. So for an example, when we looked at, totally blanking right now, but so a big thing for us is educational attainment. And we're able to see how that impacts. Now that was a bad example. Let me start over. One, we looked at mental health days. That was the factor we pulled from county health rankings and kind of compared that to counties who were recognizing that mental health and substance abuse is a big program, is a topic they're focusing on. And so we were able to use county health rankings to have a number to attach that to. So it isn't a perfect science and it isn't the best data, but it is something. And it allows us to just have a starting point and to just see, from the percentages on county health ranking, you can see, yeah, this is a real problem we need to focus on. Whereas maybe, in our communities in the mountains, they're fairly healthy. So obesity isn't as big of an issue as in other parts of the state. And so maybe we'll focus more on diabetes than obesity. And so that's just a way to kind of pinpoint where to begin intervention until we get better data.
This is Carol. I'm going to intervene, just being timekeeper. I'm concerned about the time, and I want to be sensitive to your participation in the conference. Natalie, do you have any comments before we move on?
Super job, Marguerite. I would just say that, your governance in your context takes on a completely different or new set of tasks, given that you're brokering between, erstwhile competitors or at least, organizations that very much want to stay independent. As far as social determinants of health, there are more and more tools on the market around collecting standard data. I don't think anyone's really gotten to a great point with regard to analysis and then, solving by creating networks of these services. But I don't know if you're aware of NACS, the National Association of Community Health Centers. They have a project out there. I think it's called Promise. I'm getting it wrong. But they have an assessment tool that they are piloting. If you know anyone from the Iowa PCA, or if you don't, we can put you in touch. But they're one of 2 pilot sites.
Oh, yeah, I would really appreciate that.
And what was
That would be great to hear what they're doing. So thank you so much.
What was the name of that group?
The National Association of Community Health Centers, NAC, is based in, I think, Bethesda or DC, and they have a project that's funded, and I know it starts with a P. I think it's called Promise, but we'll let the whole group know what the program is called, and we'll offer up a contact there to talk more about it.
I'm starting a to-do list, so that's something we'll get to you guys via AJ. Okay? All right, before you hang up, next time you sign back online, this is for you, Marguerite, and everybody. Please, at the end of the session, don't forget to do the Survey Monkey. Okay, thanks, Marguerite.
Great. Thank you so much.
I appreciate it. Marguerite's contact information. We're going to move on to Dennis. Before Dennis talks about dental aid, when you all look at your screen, I want to give you the option to move your slides along if you wish, or I would be more than happy to move them along. But when you look at your screen, at the bottom of your screen on the left-hand side, there are arrows that move to the right or the left. Can you folks see those?
Yes.
Okay, Dennis, and so you would move it to the right. Are you comfortable moving your own slides, or would you like me to move?
I can move them. If I screw it up, then I'll give it back to you.
I'll be your shadow. No problem.
Okay, fair enough.
Carry on.
Hi, everybody. My presentation is going to be a little bit different than probably the rest of yours, just because dental and oral health is lagging behind dental medical in many ways. And Colorado tends to be pretty progressive. Oral health was named by our governor as one of the 10 winnable battles, along with obesity and other things. So we do a lot of really good things in Colorado, and yet I think you'll find that we're not where we need to be. So dental aid is old. It was founded in 1974. It, in fact, may be the oldest not-for-profit safety net dental clinic in the country. It certainly is the oldest in Colorado. When people think of Boulder and Boulder County, they think of someplace that's fairly affluent. In many ways it is. Average income in the county is probably $68,000, and there are towns in the county where the average income would be over $100,000. But we have 14% unemployment, or 14% in poverty. And the city of Boulder, that percentage goes up to 22% as soon as the college goes in session. Those college kids tend not to make a lot of money. We have 52,000 people enrolled in Medicaid in the county. The American Dental Association says an ideal dentist to population ratio is about 1 to 1,500. When it comes to Medicaid, that probably is closer to 1 to 4,500. So you can see we have major access issues when it comes to Medicaid and poverty and dental. 100% of dental aids patients are poor, or under 200% of federal poverty, and we're fairly large. We employ 11 dentists, about 27,000 visits a year to about 8,500 unique users. But, we keep plugging on. It's a very high demand situation for a very high need population. And we really, really strongly believe that everyone deserves oral health. So what are dental aid's values? Access, compassion, innovation, prevention, and high quality care. Why compassion? It's very, very important to us and important to me that when it comes to providers and staff, that we're recruiting to someone who has a strong service component to their worldview, that they can show compassion to people who may be in a very, very different place than they are, and that they can be free of judgment as they try to provide care to that patient population. So compassion has to be a part of the things that we value. And innovation has to be a part of what we're about, because we're still grant dependent. And we won't continue to get grants if we don't innovate. I think that's part of why I'm connected to this learning collaborative, to see if I can't educate myself to where medical is and see if we can't move dental in that direction. Dental aid is 100% fee for service, and most of our patient populations are Medicaid. You can see the breakdown there. The 7% indirect pay are really any third-party payer other than Medicaid. That might be when we contract with, or Boulder County AIDS Project would contract with dental aid to provide services to a couple of their clients, or Emergency Family Assistance Association, if they want to help a family out and dental is one of their needs, then we would contract directly to serve that patient through EFA. Or Imagine, who houses people who are physically or mentally disabled, and we would contract specifically to them. At this point, it's probably important to note that dental does not have any diagnostic codes. So tracking a cohort like obesity or tracking a cohort like diabetes is very, very difficult because there's not a diagnostic code that we could attach to that cohort. So we have to invent ways to do that. We might make up a code and instead of a dental fee code, we might make a code up which would allow us to track a cohort. But we don't have the ability to do that just via a diagnostic code. So in terms of governance, I'm the CEO of this organization, so I can pretty freely do what I want to do, but I do have a board of directors that I answer to. I do have a board of directors that basically hires me, evaluates me, and all those kinds of things. The board of directors is not operational, but they are strategic. And one of their core values should be our mission. So the directors are not recruited for their fundraising ability, but they are recruited because they believe in the mission and have a passion for oral health. So that's kind of a cool position to be in right now, because as we enter into a strategic planning portion, I can start to introduce the potential of value-based reimbursement and move that strategy towards that end. So it's a good time from a governance point of view to create a new strategy around value-based reimbursement instead of having to come at it from, okay, here's the strategic plan, but we have a new idea that we think fits into that strategic plan. We can actually create a strategic plan around some of the things that we would like to start to do. So moving on, this is where it starts to get hopefully a little bit, maybe even educational a little bit for where dental is. 100% of dental aid patients are high risk. So imagine everybody that walks through your door is high risk for asthma. Everybody that walks through your door is high risk for diabetes. Everybody that walks through your door is high risk for obesity. Everybody that walks through dental aid's door is high risk for our disease. And that creates some really potential things. So why teeth? Why the heck is this thing important? Why are we even there? It's a major health disparity. When it comes to oral health, we have huge health disparity issues. Dental care is the most prevalent unmet need among children in the United States. Let me say it again. Dental is the number one unmet healthcare need among children in the United States. It's the number one chronic disease of children. 5 times more common than asthma, 7 times more common than hay fever. Oral pain and infection interferes with basic things: eating, learning, speaking. More than 51 million school hours are lost per year to dental disease. More than 164 million lost work hours per year to dental disease. It's now being linked to those things you can see on your screen, but also now lung cancer, dementia, and pneumonia. So oral health is now becoming a major contributor, or at least an associative factor, to those systemic diseases. So what the heck does this mean? And why do I keep saying disease? Because it's an infection. Because it's a bacterial-caused infection that causes septicemia. So bacteria are constantly floating around in the bloodstream if somebody has this disease. And where does the disease come from? It comes from mom. If we can keep mom from transferring the disease to the baby, we have a really, really good chance of keeping that child decay-free, disease-free, oral disease-free for the rest of their lives. So what the heck does this table show us? And what the heck is a DMFT? And what the heck is a DMFS? A DMFT stands for decayed, missing, or filled teeth. It's a measure of disease. DMFS is decayed, missing, or filled surfaces. So imagine a Kleenex box or any box on your desktop. There's 4 sides to that box and a top where the Kleenex comes out. Each tooth has 5 surfaces, 4 sides, and a top that we chew on. So that DMFS becomes a better measure of the level of disease. So what Dental Aid's been doing is we've been aggressively treating mom for a number of years, going back about 12 years. And then we begin to look at the decay rate, the disease rate of children at age 3. Those children when mom did receive care during the pregnancy versus a group where mom did receive care. And each of those cohorts now is about 700 at the time of this slide. It's about 1,000 now. So you can see when mom receives no dental care, they have more decayed teeth. First row of that chart. But the decay rate between the 2 cohorts isn't really that different, 5.3 to 4.6. But look at the next one. What that's telling us, when those kids' mom still has a lot of bacteria, those decayed teeth have big cavities. And when mom does get care, those teeth have little cavities. That's the difference between that 26.5 and the 9.2. It's the difference between a kid that has to go to a hospital to get care because he's got big cavities versus a kid that we can treat in the office because they have little cavities. The difference is 45% of 3-year-olds, when we don't treat mom, go to a hospital for care. When we do treat mom, that percentage drops down to 18%. So Children's Hospital Colorado keeps 5 operating rooms going 5 days a week just to treat kids under general anesthesia that have this disease. That's 100 kids a week that are getting put to sleep for a preventable disease. Costs the state of Colorado, just in Medicaid dollars, about $45 million a year in one hospital. Not all the hospitals across the state. One hospital is doing $45 million a year in Medicaid a year. This is nearly 100% preventable disease. And we're treating 100 kids a week for a preventable disease in a hospital. It's crazy. And yet, dental's not even considered part of the medical neighborhood. We're not even in the RICO map. We're not even the Accountable Care Organization map. And if we can start to collect this data and just reduce the number of hospitalizations from dental aid alone by 20%, we would save the state over $400,000 a year. So for us, the next step isn't so much transforming a practice. For us, the next step is transforming a RICO. The next step for us is transforming healthcare policy and finance at the department level of the state of Colorado. So the mouth, at this point in time, is really, in my opinion, and in the opinion of many, is the missing piece to overall wellness and lower medical costs. And there's just some average savings for you. We can save over $500,000 a year in hospitalizations associated with cerebral vascular disease. And you can see the numbers. This is just from getting people's mouths clean, just treating their gum disease, just getting that bacterial load in the mouth lower so that bacterial spread doesn't become systemic. Now look at the palm of your hand. Just put out your arm stretched, your hand, your 5 fingers together, and look basically at the palm of your hand. Now, if that palm of your hand was red and infected and bled, do you think it would be ignored? And yet that's about how big the mouth is. And that's how contributory it is to these systemic diseases on this dollar slide that you can see. So there's just a ton of work to do around oral health, just a ton. And we're not even to the point where we can attach a diagnosis to follow a cohort. Dental aid can, because we've been doing it for a long time. But the work is just begun when it comes to oral health. And I guess more than anything, that's the message I kind of wanted to send, is how important this disease is and how contributory it could be to medical cost savings, and how value-based reimbursement could really begin to fit into changing the healthcare environment in Colorado and really in the U.S. So, open to questions.
So, Dennis, one of the first things we talked about was learning to follow the money.
Yes.
In Colorado, Medicaid, there are health plans, there are RICOs, and the state has been historically very reluctant to shift financial risk. So why even bother with the RICO?
You mean why not go just to HIPAA?
Yes.
The healthcare policy and financing? Well, I think I will. Right now, there's 3 major departments that would have an influence in this. The first one is the Department of Housing and Human Services. The second one would be the Department of Public Health and Environment. And I've got the Department of Public Health and Environment on my side, and now the Department of Public Health and Environment is actually the one who is convening the meetings with healthcare policy and financing. And so I think you're right. I think it has to be at the state level, and it has to be at the department level of healthcare policy and financing is where we'll start to begin to see the change.
You know, the cohort of your, sorry.
Go ahead, Natalie.
Dennis, it's just been really so interesting to have you here, because if more of the entities in Colorado had financial risk, like the RICOs, I can guarantee you this would be different. This lends itself to a wonderful kind of bundle. You know, it's very clear what the set of prescribed services would be. I bet it's reasonable to back your way into a per capita cost, and it's unfortunate that the RICOs don't have an incentive then to share dollars saved. I don't know what incentives your hospitals have. If the CHC, if that's a major source of revenue for them, it's zero, and then you've got to get the state to help you move them, because if it's a profitable line of business for them, you'll need the advocacy.
Yes, I agree. Now, like Children's Hospital Colorado, CHC, even if we reduced the utilization by 20%, the Medicaid access issue, the health disparity is so large that we're years away, we're decades away from reducing that 5 ORs 5 days a week going to dental, just because there are so many kids out there that haven't even gained access to a dental clinic. 25% of the kids in this state, their first visit is still to an emergency department. So there's another whole area where we can begin to start to really educate people on is emergency department utilization for dental services. That's another, area that's just terrible in its misuse of dollars.
But you also said that nothing around the practice needs to change, and I'm not sure I agree with that, because what you're going to have to do with regard to patient engagement, I know for myself, I know for my family, I know from others, it's not fun to go to the dentist is a source of fear. Quite apart from the access issues, their thought to how you would engage patients differently to get them to understand and take up the preventive care needs they have?
Yes, I totally agree with you, actually. The practice of dentistry does need to change, but the practice of dentistry within dental aid doesn't need to transform a lot. And I was referring to that more. Dental aid providers are educated in anticipatory guidance and motivational interviewing. And so we're a little bit ahead of the curve. I'm not saying we're where we need to be in terms of actually trying to look at behavioral modification and measure behavioral modification. But I had lunch last week with a classmate of mine who practices in Breckenridge, Colorado. Actually, he's the mayor and the dentist, but that term, medical neighborhood, he'd never even heard it before. So for a private practitioner, a successful private practitioner, to think about engaging with the hospital and engaging with his physician counterparts, the private practice is a long ways away from that yet. And 80 to 85% of dentists still practice in a very autonomous setting called private practice. So dentistry does need to change significantly. It's just my 11 dentists are beginning to get it.
This is
Dennis,
Jennifer.
thank you very much. I'm going to move us on to our next speaker. I think that's Tracy, SIU.
Hold on, my computer screen just went dead.
Okay.
I'm here. And I want to apologize. They're replacing air conditioners above my ceiling, and so it's very noisy. So I apologize if you hear lots of background noise. So I am with Southern Illinois University School of Medicine, which is in Central Illinois, with the Family and Community Medicine Department. And we're an FQHC, and we're a residency FQHC, which is even rarer. And then we have 4 FQHC residency sites across the state of Illinois. Plus we are just adding 6 more scope sites for our FQHC. So we're growing very quickly. So the FQHC I'm highlighting here is my one office right here in Springfield. So it's only one of 16 sites that we have. But basically at this FQHC, we're providing 58,000 visits a year to 22,000, a little bit over 22,000 unique patients. And we have 51% who are Medicaid, and 4,000 of those having 3 or more chronic conditions. And so this is a picture of our building, and we are just completing our new construction. That was our local hospital. Because of our close affiliation with them, this is a structure they have built for us for our patients to be seen in. And we're excited about it because we come from a very old building otherwise. So my focus is on developing a plan with Molina, which is our Medicaid managed care system here in Illinois. All of our others have left the area. And we are having discussions about incentives and how those will be paid to us for high utilizers that we manage. We are looking at January 2017 as our start date for that. So in our governance-wise, we have MOUs in place with our two main local hospitals. I'm able to get a large expansion of data, including even urgent cares, et cetera, because they're all owned by one of the two hospitals in the area. We are working on our agreement with Molina for data sharing. We've done that on a pilot basis of referrals that they send to me. They send me one referral every week, and as I have positive outcomes with those referrals, then they start to share more information each time. We're able to query data out of our EHR and our SIU healthcare setting in our FQHC only. Our other SIU healthcare entities are not as queryable in data. And we are developing a new governance structure here at SIU because we have a School of Medicine plus an SIU healthcare setting. And they're run separately, but our new dean is bringing many of those pieces together. So we're setting up a new structure that will handle population health here at healthcare and School of Medicine, and that goes effective on October the 1st. So this is a picture of what our new structure will probably look like. But you'll see we have a School of Medicine Office of Population Science and Health, and then an SIU Healthcare Office of Population Health. And I am the Director of Population Health Integration. I'll be moving into that new position. Plus, then on the School of Medicine side, I'll be the Director of Education, which is one of the other branches on there. So we're hoping that by doing this, we can create an educational site for our students while also improving the care that our patients are seeing. So again, it's the new structure put into place. We believe this will help us a lot because on one arm we'll have our legal team who will do a lot of our contract negotiation, which right now we're missing folks who are interested, who are really taking on the lead for value-based direction. So my focus is our high-risk cohort. So within my one clinic here, I have approximately 3,000 super utilizers of ED and inpatient, and 2,500 of those are in the ED. That means they have more than 6 times that they've been sent in the ED in the last 6 months, are greater than 3 hospitalizations in the last 6 months. Their ages are broad, and they all have risk profiles over 10 by the insurance companies. And so again, when I look at this, we have to remember that 5% of our Medicaid beneficiaries account for 54% of our expenditures, 1% account for 25% of the total dollars, and 83% of those have at least 3 chronic conditions or more. So it really is fitting with what our population looks like. We have 2 FQHCs in town. They're 2 competing FQHCs. And we're ranked number 1 when we were talking about county health rankings. We're ranked number 1 in Illinois for provision of health, but we are ranked 62 out of 102 counties for health outcomes. So we have some major health outcome issues. So my intervention deals with engagement of the superutilizers because this is so key. And so what we have been able to implement is a community health worker model. And this is currently funded by, I have 2 geographic sites here in town that we're using community health worker models, and I have grant money of $900,000 to fund those programs. And there's a lot of evidence behind using community health workers. As you can see here, it's really been demonstrated to show effectiveness in terms of improving service quality, cost savings, and improving health and quality of health outcomes. And in many other programs, it's been demonstrated to have cost savings of $7,000 or more. My second intervention revolves around our payment model structure. And so August 31st, we go live with our chronic disease care management billing system, and that's what I've been working on the last year. And again, this will allow us to bill for those patients with chronic conditions that we are case managing. And my community health workers will be able to bill for the services they're provided, which is the key to keeping my community health workers because I need to get them off of grant money. We also have been looking at different payment structures of how to document services provided by service agencies in the community. And so we're currently looking at a new integration between my service agencies documentation spot and my EHR system. And we are working on an interface for that, because in that way, if they have a contractual relationship with us, we're able to count a lot of their care coordination back towards our patient care. And then my final intervention that we've been working on is enhanced access and capacity. So we have a limited number of new patient visits available, and I've been able to contract with our clinic to have just 15 slots reserved for my patients that come into my community health worker program. And so we schedule them right away, they get seen right away, we can see them as many times in a month as we want, so we can maintain that engagement, because for so many folks that makes a huge difference. Previously, we were more than 2 weeks out for third available appointment, which really would break a lot of our engagement processes. And we were unable to handle same-day appointments just because of the number of patients we were seeing. The variability in providers' ability to handle the complexity of our superutilizer patient was another big thing that we ran into. So we just developed now, and we started this last week, a new clinic called Comprehensive Care Clinic, and it's for superutilizers. It's every Friday morning, and again, I schedule patients in there. It doesn't have to go through any other system but me, and it incorporates a social worker, a PharmD, a physician, and a community health worker. And we are able now to bill for the MD, the social worker, and we have it set up to start billing for the health worker through CDCM. So we believe that that will really help us to be able to support this intervention because of the cost relationship to that. So I wanted to highlight the difficulty of developing a new type of clinic setup. And so scheduling was a huge issue we had to work through. So we used what our behavioral specialists scheduling process looks like. And I do all the scheduling, so that removed the front desk, that removed the nurse involvement, because what I found a lot of times when our patients who are superutilizers are calling those individuals, it almost is more harmful to my engagement process than not. And so we've been working on education, but in the meantime, we're just kind of bypassing them so that we don't lose engagement processes. And the big thing was always the question of the duration of appointment types. And so, and the appointment visits, everybody wanted a 15-minute or an hour, 30-minute slot or a 10-minute slot. And I've created a new complexity rating scale that allows me to determine the length of the visit. And with all of us seeing the patient, we're able to work it out so that it doesn't matter if we end up with 5 patients there at the same time. No one's ever waiting to see someone without someone in the room with them and having a conversation. So that's really good for engagement processes. The information we're collecting, we're measuring our impact on the reduction in our ED visits and our decrease in no-show appointments, plus also our increase in patient engagement by measuring people calling in, canceling their own appointments or keeping their appointments. Them calling about their own appointments has been shown to be just as much of a measurement of engagement as just keeping the appointment. And we also are looking at improvement in measures specific to the client's disease and health state. So we're collecting information from the ED, our no-show rates, our cancellation rates and show rates, and then our specific disease measurements. That is what I have.
Great job presenting information in a concise amount of time, Tracy. Comments for Tracy?
This is Jennifer at Lakewood. I just have to say I took notes during your whole thing. The idea of that comprehensive care clinic is phenomenal, and what we're working on, a lot of our initiatives are very, very similar. Good job. When did you guys start this whole process?
So for the last 2 years, I've ran my own clinic with medical students and documented how much we would achieve in billing by doing it, because I couldn't convince people we needed to have the clinic. And when I was able to document that we would be able to bill almost at a 300% level better than what we're doing now for this clientele, it didn't take them long to decide to accept it. So we started building the templates for it probably in, I got to think back here, about April. But to convince all levels for it to go live was a little bit more difficult. So it's probably, it's been a 2-year data gathering process, but really in March and April is when we went really live and trying to sell it to, my billing folks, my front office staff, all those individuals. So we met with each of them so they could get buy-in so that a patient, when they walk in, doesn't get a negative message at any point about that alternative clinic.
Great job. Tracy, this is Susie. What are the barriers to patients getting to that clinic on Friday?
So we picked Friday for a few reasons. Because my community health workers are seeing patients in the community Monday through Thursday typically, because we find that when our other agencies are open, so that's when my community health workers are taking them to there. So we picked Friday because we did not want to cross over any other time that maybe they needed to get uptown to get registration to the food banks, et cetera, like that. The biggest barriers to any of my patients is transportation. We do not have a very good public transportation system here in
Springfield. That's exactly our problem, yeah.
And so by having my community health workers, the patients I select, they transport them to our clinic. So that makes us have 100% show rate. And that's one of the biggest issues that we've done. But we've been able to demonstrate that by having a show rate, we're making more money. So I've been able to get money from my institution to cover the transportation because they're really making money by getting the patients there and saving on the ED visits.
Great.
I can't help this question. On Dennis's presentation, you've assembled a nice interdisciplinary team. Any consideration of involving dental?
So we have 3 Medicaid dental providers here in the Springfield area. And so I have an organization of 32 service agencies that we meet regularly to talk about case studies and identify how can we start to fill gaps in these areas. And then, so really my dentists are at the table, or at least starting to be at the table, and I have good relationships with them. One of the local 2 hospitals I was talking about is opening a dental clinic within the hospital itself to direct ED visit folks that are coming there because of dental issues to their dental clinic in the hospital. And so we have really been able to address dental care very well, we think, for our clients. Our biggest obstacle is oral surgery, of course. And we are working with our dental school to potentially open an oral surgery suite within our FQHC.
Natalie, do you have any comments?
Fabulous job.
I hate to be the timekeeper. Time is our enemy, but each presentation has just been phenomenal. But I'm going to move us on. I think Cascadia, Renee, are you next? Let's see.
I am here.
Take it away, Renee.
All righty. So Cascadia is one of the largest nonprofit behavioral health providers for adults in the state of Oregon. We serve not only adults, but we serve older adults, kids, families, mental health, addictions, kind of the whole gamut. Really our mission and our values are around healing, homes, and hope. And we have almost over 1,000 employees, so we're a pretty large organization, and we provide services primarily in the Portland metropolitan area. However, we do have some clinics outside of that area as well, but we're looking at about 15,000 individuals served each year. Okay. And so thinking about the services that we provide, we have a number of different divisions. We have our outpatient services, which includes addictions, outpatient mental health, and serves the entire age continuum. We have forensics programs that are not only community-based and in residential sites, but also within the prisons. We have homeless services programs that do a lot of community-based treatment kind of in the communities where a lot of people are homeless. We provide peer-delivered services. We have urgent and emergency services, and we also have a big housing development within the agency as well. So I feel like the past 6 months of my life have really been spending a lot of time thinking about contracts and service delivery models and partnerships and all that stuff. So the timing for this collaborative really worked out well for me because it helped me to think about things in various different frameworks. So that was really helpful. And we're also just kind of getting, we just entered into the new fiscal year. Our fiscal year goes from July 1st through June 30th. And as we were looking not only at division and program budgets, but the larger agency overall budget, we realized, a trend in not renegotiating contracts. So we had a lot of flat contracts that hadn't grown in, 5, 7 or more years. And one of the things that we are doing is really looking at making sure we're getting paid for the services that are provided in a way that's sustainable so that we can continue to provide them, or at least get an increase to help offset some of the costs. So that's one of the things that we're doing around contracts. But Oregon was one of the states that was awarded the planning grant for the Certified Community Behavioral Health Care Clinics. And we've been spending the past 9 months or so really getting ready to hopefully implement that model, thinking that Oregon may be one of the 8 states chosen to implement the 2-year demonstration grant. And the way that it's set up is that, we have to do all kinds of things like creating policies, doing a needs assessment, but we also have to do a cost analysis report, which will inform our PPS or our RAT payment. For the first year, Oregon has decided not to do quality bonus payments for this grant, and I think that's probably just a capacity issue and trying to get settled and figure out what we're doing. But we're hopeful that as we kind of get through the next couple of years and really are able to do integrated care and find models that work, that we'll be able to work towards incentive bonuses. However, we are working with some of our local payers, our coordinated care organizations, to discuss the possibility of risk sharing. And just to kind of give you some context, when we work with primarily with two CCOs, and one is a fee-for-service model, and the other is a case rate. So that always makes for really interesting budgeting. But about 70% of our clients are with the CCO that does the case rate. So there's also a risk corridor in making sure that we provide at least 80% of the services that we said that we will provide based upon the level of care for the individual served. So I realize that this graph is super small. You can't really see it, but it looked pretty big on my screen when I was doing the PowerPoint. And at the very top we have our board of directors, and this is basically just our administrative management org chart. So you'll see that we have our our CFO, our chief clinical officer, our housing VP, our chief medical officer, emergency services, and kind of all the way across the spectrum. And this is the org chart for our board of directors. So we'll see that at the very top we have our board, and then underneath the first little head is our CEO, Daryl Walker, and then we go down into the various different organizational structures within Cascadia leadership. So Cascadia is considered a safety net clinic for the Portland metropolitan area. With the ACA expansion back in 2014, we were one of the only providers who did not shut our door to the expansion. Over the period of about 6 months, we saw some of our programs literally double in size, going anywhere from 4 to 500 all the way up to 1,000 in about 6 months. So we serve people that need services, and we figure out a way to make that happen. So a significant portion of people that we do provide services to would be considered to be in the severe and persistent mentally ill category. So not only needing therapy, but a lot of support around case management, connections to the community, and really thinking about all the different domains in health and wellness. So when we're talking about the high-risk cohort, or one of the high-risk cohorts at Cascadia, I'm really thinking about those kind of what we would call level C SPMI folks, so people who have been receiving care for a number of years and really do have a higher acuity and need some more support, not only, again, with therapy, but also all the wraparound services. So if we continue to kind of narrow that population down further, looking at individuals who are also prescribed atypical antipsychotics, individuals with very complex medical conditions, including diabetes, and then thinking about individuals who have really high ACEs scores and who are very likely to have chronic physical health conditions down the road. And let me go to the next slide here. So knowing that these are the individuals that are typically most at risk for developing chronic diseases, one of the things that we are working on is developing clinical pathways. So thinking about how we can not only, collect data and use it very meaningfully and within the treatment team, but how we can also use our data to help us identify individuals at risk and really kind of doing the prevention piece. So, it's always great when we can help people from getting sick instead of waiting until they get sick and then, add all that good stuff to the treatment plan so we can bill for the services. And we really think that the certified community behavior healthcare clinic model is something that will really support this and organize how we provide services. So we're talking about a model that includes care coordination, targeted case management, treatment of both in mental health and addictions, access to primary care screening and monitoring. And what this will allow us to do is really have a robust population management model. So 3 of our 4 outpatient clinics are applying to become CCBHCs, and I'm just really excited at the thought of capturing all the data and thinking about how we can not only look at the division as a whole, but then start breaking it down by clinics or by programs or looking at things by race or ethnicity or gender, and then providing culturally appropriate interventions to best support the needs that the people have that we're serving. And then, of course, coordinating care, whether that's with on-site primary care through our CCBHC, with primary care providers in the community, or whatever types of care resources or services people are receiving outside of Cascadia so we can best support their treatment and recovery. Whoa, that got really small on me. So so we're kind of in the midst of everything right now. We're wrapping up our application process to become a CCBHC, and we're really thinking about, care coordination and what our definition of care coordination is and where and with whom that function sits. So we want to identify 1 or 2 key folks on each team who do the majority of the care coordination. Do we want to have an expectation around everyone doing a little bit of care coordination? So these are some of the conversations that we're having around what makes the most sense around the care coordination piece and, and what makes sense clinically, but also how we can support this financially, again, in a fee-for-service as well as a capitated payment structure. And then considering what this transition is going to look like as we move towards a team-based care model, because right now we're still kind of in the place where you have a primary clinician, and that clinician probably does 85 to 90% of the work for a client. So as we move towards team-based care, really kind of using what care coordination and what that will mean for the team and for the individual. And because we'll have to report out on this, we need to make sure that we have the billing or the encounter codes for care coordination so that and all the other services that we provide so that we can demonstrate this to our funders and to the state of Oregon. However, we're very fortunate because I feel like we have access to a lot of data. We have a pretty good EHR. We use Essentia, which was recently bought by NetSmart, and NetSmart is, from what I understand, pretty involved in CCBHC efforts and really wants to support their clients in meeting the needs of CCBHC. So we have access to a lot of data collection through our EHR. We have a business intelligence team, and they are amazing. I can just send folks an email and saying this is what I'm hoping to have access to, or this is what I'm hoping to learn, and they somehow amazingly are able to pull data and provide it in a way that makes sense with graphs and charts and bars, and you can break things down and build things up, and they just do amazing things that really help us argue our case for why we should or shouldn't do things. We also have access to claims data from the CCOs, and we do have some partnerships like with Portland State University, for example, as they've helped us through our PBHCI grant through SAMHSA, and they've done a lot of evaluation and data collection for us and then provide us with reports to provide the services that we need to and make sure we're getting the results that we want. And I think that's it. That's kind of the brief rundown. We're very much in the thick of it, but this has been a great opportunity, and I appreciate having various frameworks and different disciplines to help me kind of think about things differently, and it's been super helpful, so thanks.
Thank you, Renee. I think on every call you've helped us to illuminate just the importance of data, and you've been a role model to us, how you've been able to get the data and use it. And really appreciate your talk in the beginning about you are really demonstrating as well following the money. Sometimes it's easy to just kind of stay with the contracts you have, but keep shaking things up. How can you look at it? What can you do for you? In the interest of time, I'm going to ask Natalie if you have any comments before we move on to Susie at Alta Point.
Move on.
Okay.
Hey. Okay, so I'm Susie Boucher. I work at Alta Point Health Systems. We're a behavioral health provider in South Alabama. We cover 3 counties. I wrote about 3 counties that we cover: Mobile County, Baldwin, and Washington. We recently, as of August 1st, merged with 4 additional counties that are much more rural in the northern part of the state, actually the north central part of the state. We serve about 23,000 individuals annually. About 70% of our patients are considered low income. Last year, we had about 24,000 hospital admissions. We have 2 inpatient freestanding psychiatric hospitals, one for adults and one for children. We have about 25 residential group homes for adults, as well as adult community supported housing and apartments, adult foster homes. We have 3 transitional age residential programs, as well as a hospital-based residential program for children. We operate a school for children with behavioral health problems within our children's psychiatric hospital for kids in the community to come in every day. We have homeless support, outpatient substance abuse, as well as mental health, a crisis response team, and we do jail diversion and things like that. So let me see. Alabama is shifting from a fee-for-service Medicaid to managed care. We're doing RCOs, so these are local nonprofits who will come together to manage the funds from Medicaid. Right now, there are 2 RCOs in each region. We've had major stalling in the implementation of the RCOs. Alabama did not expand Medicaid as part of the Affordable Care Act. In fact, a family of 4 making more than something like $4,000 a year would not qualify for Medicaid in the state. It's very difficult for healthy adults to qualify for Medicaid unless you're a parent, and women can get family planning only, which covers very few services. So we have a huge population who's very much uninsured and in need of health care and can't afford it, and we have a lot of the problems that then just go along with poverty, especially in some of the rural areas. Alta Point is a risk-bearing member for one of the RCOs in our region, which means that we had to put up funds in order to be a risk-bearing member, like a pay-to-play kind of atmosphere. As of right now, the state legislature is in a special session today. They will be voting tomorrow about putting a referendum on the ballot to amend the state constitution to allow gambling, because they're hoping that the implementation of a lottery will help fund Medicaid. That's how desperate we've gotten. There's a $75 million Medicaid shortfall in the state right now, and without that, we can't move forward with the RCO. So if everything goes through in November, there's a tentative start date of April 1 of 2017 for the RCOs. It was supposed to be October 1 of this year. So we're all just kind of preparing and hoping for the best. This is our governance structure. I got rid of a lot of the stuff on the side just to show that we have a board of directors who, employ the CEO. We have a chief of staff who is over all of the HR and things like that. Chief information, chief medical, chief quality this is my area. So I'm under the centralized and managed care services department, and under here is where we have utilization review, care management, and some care coordination. And my department was created after the 2013 closure of one of our state hospitals. We have one state hospital left in Alabama that is still open. So we help track people. We are really responsible for making sure people are moving throughout the continuum, that they're in the right spot. So we've started doing some utilization review in anticipation of the movement to managed care. The cohort that I'm looking at for this project, these are our, what you might call a super utilizer. So they're patients with Medicaid. They have a primary diagnosis of major depression, bipolar disorder, schizophrenia or psychosis, ADHD in children, or they can have a co-occurring SMI with a substance abuse disorder, as well as having one of these outlined chronic conditions that were defined by the RCO, and having one or more psychiatric hospitalizations in 12 months, or used the emergency room twice in the past month, or have missed more than 2 appointments in the past 6 months. The interventions that were just 3 of the interventions that we're hoping to implement. One would be to do medication reconciliations post-discharge. And this is something that we're piloting now. Within 7 days of discharge from a psychiatric facility or another hospital where psychiatric was the primary diagnosis, we're working with the RCO to accompany their community health workers into the program, and we have a behavioral health nurse who goes and conducts a medication reconciliation to make sure that medications have been filled, that they're being taken correctly, and then this is sent to a pharmacist who reviews all of the medication to make sure that everything is okay. One of our biggest problems is patients are in the hospital, they get very stable, and then they come home and they don't fill the meds, they don't take the meds, things like that. So sometimes having someone in the home, even helping you set up a pill box, can really be helpful and can help maintain stability. Another thing we want to implement is the Stanford CDSMP, the Chronic Disease Self-Management Program. This is a program that can be very empowering to patients and their caregivers, and supportive people in their lives to help them manage a chronic illness, including a serious mental illness. So this is something we've done 2 groups of this so far, and we hope to continue. The third thing we hope to do is implement patient care teams. So there are a few ways that we want to do this. One of the things that we're looking toward doing is creating at least one integrated primary care and behavioral health clinic. And it would follow a team approach. We would have care managers within the practice who are offering support and education, as well as teams who can go out in the event of a crisis, sort of expanding the existing crisis response teams that we have. What we're finding is sometimes rather than going to the ER or be admitted through the ER, the crisis response team can go and intervene prior to a patient being admitted, and we can mitigate that admission. So it will definitely change our process to do this, and this is something that we're still working on, how we're going to go about identifying patients and really working with our current workflows. I work really closely with our Access to Care department, and members of my team will also work closely with them to help identify patients, but also to track them and make sure they're getting what they need. We currently monitor inpatient admissions and discharges, but we would have to do this a little bit more closely and apply risk stratification guidelines to determine who meets criteria and who doesn't. And we will assess to see how patients are doing. And we can use, we currently use MCG, which is formerly Milliman Care Guidelines. They have a wonderful tool for conducting utilization review, and their behavioral health guidelines are really robust and provide great information and allow us to document using what's in our EHR and provide a very clean trail of progress. So currently we're doing that for inpatient, but this is something we would then expand to different levels of care. Currently, we use NetSmart's Avatar, so we have a lot of information, and we have some great reports for getting that information out. So we'll continue to use our daily admission and discharge report for the hospitals. We will probably start to review our crisis response team reports to identify, who needs more support and who can we intervene to help. The things that we need to expand the use of MCG. So we need to include the outpatient levels of care. Currently, my staff would not be able to do that, so we would need additional staff to add on because that would be time consuming. And we still need to really work with outside providers to get that data from community hospitals and emergency departments. Right now, we're able to get all of those things from our hospitals, but when we move to the RCOs, we'll be responsible not only for what's happening within our hospitals, but within the community hospitals as well. So that is it. Thank you so much. It's been so great to learn from everyone, and I've enjoyed it.
Susie, it's Carol. I'm going to jip you a little bit on the feedback and looking at the time. So, folks, if you have any questions or comments, please, for Susie, I want to be able to give her feedback, but I've been an awful timekeeper. Please write those comments down. If you can stay past 1, we'll give Susie that feedback. I want to give, I think, Jennifer, you're picking up the rear here. I want to give Jennifer a chance to talk about Lakewood.
Okay, this is Jennifer. There we go. So again, I'm from the Experience Director at Lakewood Health System. We're an independent rural healthcare system, literally in the center of the state of Minnesota. We serve a very rural area. Our population tends to be aging, and we also serve 3 of the 5 poorest counties in the state of Minnesota. So we have a lot of challenges around us as well. We have a 24-bed critical access hospital. We have 6 clinics, 5 of which are primary care, and then we have a dermatology clinic as well. We've put them as satellite locations in the different communities around us to try to improve the access to care of people that we serve. We have a home care and hospice agency, a 100-bed care center, 2 assisted livings, and then we do have a 10-bed inpatient geriatric behavioral health program as well. When we look at our value-based contracts, we have a number of them currently. With Health Partners, it's a health plan. We have some quality incentives and gain sharing, but there's no downside risk. We started that contract in 2014. With Medicare, our ACO, again, it's a governmental health plan. There's a partial risk there. We just began that in 2015, but in joining the ACO, that was in about their year 2. We're now in year 3, so there is some risk there. South Country Health Alliance, we began in 2014, and we have quality initiatives. Humana also has quality initiatives. We started at the same time. And then our last one is with the Minnesota Department of Health and Human Services, the Integrated Health Partnership, or IHP, and we started that in 2015. There is some gain sharing with that as well, but no downside risk. So those are our groups that we look at. With our governance structure, I think it was maybe Renee put hers up there. I was going to put ours on there, and you couldn't see it at all. It was a little bit tiny. But we have our board of directors that starts, and then our operations and planning team. We have our CEO, and then in our C-suite, we have our chief medical officer, nursing officer, operations, and finance. And then under them, we have 4 divisions that are headed by vice presidents. We've got a strategy and development, acute care services, support services, and our senior services. Then our managers, directors, emerging leaders. We do have an integrated physician group that we've worked with. We worked on integration in the late 90s. So while they're their own business, they actually work exceedingly well with the system and do a great job to support that. And then lastly, we have our district board, which is a second board that has people elected from all of the areas and counties in which we have clinics and services, and they come and serve on a board to kind of oversee that and give us that community perspective as well. With our high-risk cohort that we picked, we also, very similar to Tracy, we went with our high ED utilization group. We noticed when we really started compiling data probably within the last year and really were able to identify that group of people that are using our ED often. We found that they were the same group that tend to have a much higher readmission rate. They do tend to be elderly and or have the complex health status, that type of thing. And one thing we've noticed within our facility is that we really have that limited access to alternate primary care options. We had started a same-day clinic, and we're a rural health clinic, so we can't do technically an urgent care, but we tried a walk-in of sorts, a walk-in clinic where we had shorter appointments available. But interesting, in opening those, our hope was that typically our complex health status patients are those who are using the ED often. Those aren't the people who qualify for those quick 10-minute appointments. But we were hoping our younger population, the healthier population, would use those and open up appointments with the primary care physicians to see our complex patients. When we look, oops, I hit the wrong button. When we look at some of our interventions, how can we really work with this group and make a difference in their lives, and then also in our the way that we're utilizing our resources. Number one, we implemented follow-up appointments in the ED. So when any patient comes into the emergency room, but especially if they're a high utilizer, it kind of gets tagged, and we make sure that we have their appointment scheduled before they leave the ER and that it's with an appropriate provider. And then we also have been really tapping into our home-based services. Like Tracy had said, they've got their community health workers. We actually hired through a grant a community paramedic. And this person could be put referrals in through either hospital discharge if a provider or the team up there noted that this person was high risk. They would send the community paramedic out within about 2 days or so to just check and make sure the transition was going well and things were going well. But then we also implemented that service through the ED. So if the emergency room provider said, yep, let's get this person within a couple of days, but maybe they had to wait 2 or 3 days, they would send the community paramedic out the next day. To the best of my knowledge, we don't get reimbursed for those services. However, again, we're making savings in other areas and found it to be just so important for our patients that was something that we're working on. The other key component that we're focusing on is our care coordination team and our use of our medical home. We've had a medical home program in place for quite some time. We were one of the first in Minnesota that actually developed the medical home program. However, our care coordination, as I think I'd mentioned in some of our other sessions, we truthfully did not go well last year at all. We're making a lot better strides this year, but it's one of those things that we're implementing one step at a time. I think one of the things, too, that was mentioned in this group is just making sure everyone's functioning at the top of their licensure and at the top of their title, and that's been something we've really focused on, making sure that we're utilizing people wisely. In that, then also some changes in process and practice. Again, with those care coordinator, with that said, their job description and updates, we've revamped what people are doing. We gave our RNs in the clinic, we changed it around. They were doing primarily our callbacks and talking with patients, et cetera, but we actually put them as clinic managers and had them overseeing the whole clinic and all of the team members. In doing so, people really, we've seen the communication improve tremendously. They do huddles every day. They're able to identify, okay, these people are coming in today, let's make sure we get them connected, or we're a little concerned about this, check with the provider, see if there's things they want us to do ahead of time. And then the other focus to make those other things happen is just really identifying and filling in those gaps in care. So when we run those reports and we pull them out, or we've identified this cohort or this group, how do we then make sure that we're following up with them through primary care so that they're not having to be followed up in the ER or on discharge from the hospital. So those are some major changes we've done in that. And lastly, when we look at our current reports and data sources, Lightbeam is the warehouse that we're pulling most of our data from, and that's where we're going when we're focusing on. I think another quote from this group was, don't let perfect get in the way of really good. And looking at all of those different data warehouses and the different ways you can compile data, we've got some through our ACO dashboard. A lot of our quality reports come from Minnesota Community Measures. But really, we've kind of chosen that Lightbeam as that consistent one-stop shop at this point in time where we can really manage it and watch those. And then we're looking at our dashboard and our quality reports to see what type of ultimate impact we're having, outcomes from how we're managing that data through Lightbeam. And that is a quick version.
amazing how you got that done in record time. Really appreciate that, Jennifer. Thanks for staying on the phone with us, folks. It is 1 o'clock. And does anyone need to sign off, maybe stay with us another 5 minutes or so? It's okay. Designated time was 1. Just declare yourself if you have to sign off.
Hey, Jennifer. So we work with another IHP, and with the reports that they give us are kind of less than what we'd ideally like. So we're kind of doing our own thing. Do you work with the claims from one or more of your payers, including the state?
That is a great question that I can, I'll share my understanding, but the finance part I truthfully defer to our analysts almost always. But what we've done is that's one of the reasons we chose our LightBeam, because it has all of our patients, whether they're in an ACO or they're with one of our one of the groups that we're monitoring, whether it's Health Partners or the IHP, and they all come in there, and it's generated, includes their, like, the payment history, where they went for services, how much it was, reimbursement, et cetera. So that's kind of why we've decided let's just stick with this and go, because we can see some consistent data there. We do compare it when we get reports from our IHP. They go ahead, again, we have a financial analyst and a claims team. When I talk about the divisions within Lakewood, one of the things that we established within our strategy and development is we actually have whole claims council that gets together, and they look at all of that and see how can we use it to the best of our ability, where do we need to have improvements, and that type of thing. So we have put a whole group together just to manage that and compare it to make sure what we see is accurate.
Okay. Yeah, it does help to do things for as much of the patient panel as possible, to do it consistently. And I imagine your different payers are sharing different types of data. One of the nice things the state of Minnesota did, at least with IHP, was create kind of common cross-payer standards, like the Minnesota Community Measurements. Everyone knows and deals with that. Attribution is standard across payers who participate in the IHP, which is all of Medicaid. So it is nice that the state did some of those framework things.
It is wonderful. And truthfully, the part of that, sometimes, we're pulling things and we're looking at data, but it also helps with your staff engagement and your provider engagement, because you can compare how you're doing with your cohorts. Sometimes, I've probably even been guilty of this myself, where you think, well, that doesn't apply to us, or that would be for a really large system. And really, when you have your whole state, and like you said, everyone has to report out, it really helps you say, okay, well, you know what? These guys are able to do it, so we have to figure out how to do it. And it is really nice to have that kind of standard and benchmarking.
Any other questions, comments for Renee, or also for who did we miss? Susie.
This is Tracy, and I was going to say we've looked at the community paramedic model too, and I think that's a really interesting. I think it's a really innovative approach for engagement. And so we've also looked at how do you build the community paramedic into the ambulance services in the area, because they're often the ones who are identifying a lot of these super users. So, so I'm glad that you're able to pull that off, because it's also one of the areas that we're looking at.
Yeah, one of the challenges in that regard is finding people who can serve in that role. And again, we're rural. There's a couple programs in the state of Minnesota. It's newer, and people who have a passion for that, it's a great match for their gifts and their, what they're doing. But it is really hard to find people. The last conference they had in Minneapolis, I think there were more people there looking for community paramedics to bring back to their facilities than there were community paramedics there.
Any other comments, questions before we bring this VLC to a close? I would would just like to summarize by saying I think you guys have been wonderful participants by your presentations today. You've obviously heard some of our lessons learned about the importance of leadership and governance. It was interesting to hear all of your different models and how their vision and how they support your program was clear, how you got the message of following the money. Some places have contracts in place that help them. Dennis, you're our Don Quixote. Please keep in touch. Let us know your efforts to spearhead so they understand the risk has made a difference, I think, in each of us, and someday your time will come. I think you've clearly demonstrated today how you based your work on fact. I was very impressed. I'm thinking, Susie, we didn't give me much feedback. Just all your interventions had professional citations to it. So it's, again, not subjective, but it was based on fact, evidence-based guidelines. Each of you did a very nice job talking about the importance of using your data. And so not only to get your programs going, but don't forget to be continually using a quality process, using your data to measure your performance. Each of you talked about your technology, some of the challenges. We didn't specifically talk about it, but I think appreciating the culture that you work in, and that was very clear. Some of you referenced the team in your organization. You can't do it alone. I think about Tracy. It sounds like you're a one-woman show down there, and you're scheduling the appointments, but I know there's a team behind each of you that supports your efforts. And I don't know, was it you, Jennifer? You stole my line there. Don't let perfect get in the way of doing good. I'm very impressed with each of you as leaders to take the lessons learned from this VLC and carry on and make the change and the improvement in your population, some of the lessons you've learned from this, and carry on and being the leaders that you are. AJ, Natalie, I don't know if you wanted to share any closing thoughts.
Thanks for sticking with us. We learned a lot from you as Optum. And, this isn't an easy thing. You all have day jobs, clearly. So really appreciate your participating in this with us.
And then here from the SNAC team, we really, really like exactly what you guys did today. Show us all the challenges and what you've been going through as organizations and what you've learned throughout this VLC. And if it's okay with all of you, we'd really like to use this from our perspective to kind of show the challenges to, how we can use it as learning experiences moving forward. And I'll send an email out about that later.
Sounds good. And we owe you the information on the NAC program. We've done a little research. We'll get that to AJ and he'll get it out to you. Your comments have been very important to us throughout the collaborative. You've done the Survey Monkeys. We've reviewed them. We've tried to incorporate some of your comments. So this is your last one for the session. You've been honest throughout, but really be honest on this one. Give us your thoughts. What do we do well? What do we not do well? What do we need to do for the future? So please do Survey Monkey.
Thank you all for everything. It was a great experience.
Yes, I was going to say, I think that the amount of work was just appropriate enough for very busy people, but it kept us on target, so, but not over pulled us, so it allowed us to be engaged. So I wanted to thank you for creating that nice, even filter.
Good.
Take care. Good luck on your value-based journeys.
All right. Thanks for staying with us.
Thank you.
Have a great day.